I think I'm going to provide a good contrast to what Dr. Ciampi and Dr. Powell do. I love what they do. I think it's great. There's more than one way to skin a cat. And so mine's going to be a little different. And let's see if we can do this. First, a little video.
15 minutes could save you 15% or more on car insurance.
Everybody knows that.
Well, did you know that words really can hurt you?
What?
Jesse, don't go! Jesse, no!
I'm sorry, Daisy, but I'm a loner, and a loner's gotta be alone.
Geico. 15 minutes could save you 15% or more.
Jesse?
My kids give me a hard time about liking that commercial too much, but in a few minutes you'll understand why. I've been a family physician for almost 20 years. I completed my family medicine residency in the Army in 1996, after which I paid them back with 4 more years of my life, including 9 months in Bosnia. I got out of the Army in 2000 and joined a primary care group in Northwest Arkansas that contracted with a local hospital, which owned the practices. So basically, we were hospital-employed physicians. I worked for this hospital system for 9 years, during which it changed ownership twice. Eventually, our contract became a production-based contract. But I have a long history of being slow. I was told throughout medical school, residency, my time in the Army, and my time working in that hospital-employed practice that I needed to see patients faster. I guess I will never understand what seeing patients fast has to do with taking good care of their medical problems. Thank you. I'm so tired of that. And numerous patients have told me that they don't appreciate the doctor spending just a few minutes with them than running on to the next patient. So obviously I did not do well in that hospital-employed system. By the time I resigned in 2009, I was making much less than when I started working for that hospital system in 2000. And I was very concerned about losing my house and going bankrupt. In August 2009, after lots of tears and fervent prayer, I opened Simply Family Medicine, my third-party free practice. And that's what it looks like today. A simple little place. I didn't know much about business, but at that point in my career, I knew how I wanted to practice. I basically wanted to do it my way. And I wanted to simplify things as much as possible so I could just focus on taking care of patients. A few months prior to leaving my previous practice, I started looking online for information about cash clinics. And I found multiple inspiring stories of physicians who were already doing what I wanted to do, including Dr. Robert Berry's testimony before a congressional committee in 2004. And I found the Association of American Physicians and Surgeons. I didn't know much about the AAPS at that point, but before I'd met a single member of this organization, I was able to use the information from aapsonline.org to get most of the things done needed to open my practice. I love it. I'm not independently wealthy, so I took out a small business loan in order to buy the needed equipment and to pay myself for the first several months. At this point, I don't regret doing that. But if I had it to do again, I would borrow less money and buy less equipment. I consider myself to be very good at managing patients with multiple chronic medical problems. In my previous practice, when I would see those patients, they often had Medicare or Medicaid. They would have 5 to 10 chronic medical problems, sometimes treated with 10 to 15 prescription medications, and it would take me 30 to 60 minutes to see them and document their visit so that I could bill for an appropriate level. But we would only get paid about $70 or $80 for that visit. That amount per patient, considering the time it took to see them, didn't even cover our overhead, much less my pay, my salary. That's why the hospital started cutting my pay before I resigned. My pay was the only thing they could cut from the overhead. I was especially perturbed by the fact that our practice was paying the hospital billing service about $15,000 annually, but we still had about $25,000 in bad debt annually, and that's just for a single solo practice. But in that clinic, if one of those complex patients had no health insurance, they would be billed about $125 for a similar visit. I decided that I wanted to take care of those patients, the ones who were paying their own way, and charge them lower fees by massively cutting the overhead cost of providing care for them. I also really wanted to see patients with fewer and simpler problems. I've been told that you basically select your patients by the way you practice. And that has been one of my goals at Simply Family Medicine, to see patients who have maybe 1 to 3 chronic medical problems rather than 5 to 10. Most of those patients with numerous problems have Medicare or Medicaid anyway, and they don't generally come to see me due to that. My fee schedule is structured to help me achieve that goal, although it can be very fluid, especially if a patient does have multiple complex problems. I basically decide what the fee will be for those patients on an individual basis, but they know what it will be prior to their visit. I occasionally do charity care for a new patient if I'm able to discern that they truly need it, although never for a controlled drug issue. But it is my established patients who benefit the most from my ability to determine the fees with each visit. I will sometimes do a brief follow-up visit for an acute issue and 1 to 2 weeks later, for example, an ear recheck, or on a chronic issue 1 to 2 months later, for example, a blood pressure check, for no fee. I also do short-term follow-up appointments in 1 to 2 months on some chronic issues like anxiety and depression, which family practice doctors see a lot of, for a lower fee. And my regular patients who see me frequently for monitoring of multiple chronic problems that are generally stable often have a set fee that is lower than my stated fee for multiple chronic problems, and they kind of know that before they get there. I was never very skilled surgically, and now my hands are arthritic and clumsy, and doing minor office surgical procedures would be very difficult in my practice model with no assistant. It would be very hard to have sterile gloves on for a procedure and be able to step out of the exam room to greet someone who walks in the door, which I do routinely, though briefly. My regular patients are used to it and they don't think anything of it because they know that I'm going to give their appointment adequate time. But not being able to do minor office procedures certainly takes away a good source of revenue for a family practice doctor. And most doctors who have solo third-party free practices still typically have a few employees. But at Simply Family Medicine, I really did not want to take the time to figure out how to employ someone, so I decided to practice alone. I actually opened Simply Family Medicine about 6 weeks after the hospital closed my previous practice. I basically did it all by myself, other than some help from a lawyer friend who only charged me half his usual fee to help me get my business established. There was hope that, once I got it going, my wife could quit her job and come be my volunteer business manager and receptionist. She actually did do that in my second year when my workload had increased to the level that I thought could support us. She worked with me for about a year. I like to call it a mom and pop clinic. Our patients loved it and we worked very well together. But we did not make enough in that year to continue with that arrangement, so she took another job. But she is much better at business issues than I am. And while she was with me, she created a few basic financial spreadsheets for me to keep up with the needed numbers. And those have been tremendously helpful over the years since then. I plug in a few numbers at the end of each clinic day and at the end of each month, and I easily have everything ready for my accountant at the beginning of the year. This is a sign that patients see right after they walk in the front door of my clinic. So most of the questions they might have about how my practice works are answered very quickly if they take the time to read this sign. The next thing they see is my front office window, and if I'm not in an exam room with a patient, this is what they see. I sometimes call myself a recepti doctor. My clinic is not a walk-in clinic. That's a term that I despise and a type of practice that I despise. I do see walk-ins when I have available appointments. Sometimes that is when they walk in the door, but sometimes that means coming back a few hours later or coming back the next day. Patients who schedule appointments are always my priority, and I schedule each patient for a specific amount of time based on the nature of their problem. And I usually need that much time to fully address their problem. In this age of cell phones and instant communication, in my opinion, pretty close to 100% of issues that can be addressed in a clinic setting rather than an ER can easily be addressed during a pre-scheduled appointment rather than on a walk-in basis. And I can basically get patients in for same-day appointments as long as they don't wait till too late in the day to contact me. My only clinic phone, besides my fax line, is my cell phone, and I do not answer the phone during patient visits. So my regular patients have learned to leave me a voicemail or text me and wait for me to contact them, which I do in between patients. My voicemail greeting briefly explains this and tells them to leave me a voicemail. But it's kind of fun when someone calls me from another medical facility and then apologizes for calling my private phone when they realize they are talking to the doctor. I tell them that they have to talk to me. I'm the only one that works here. So it should be obvious that in my practice model, doing a purely walk-in clinic would be difficult. My clinic is a family practice clinic. I can take care of most of the problems that other family practice doctors see with a few limitations due to my practicing alone. Obviously, that precludes doing female exams, although there have been a few exceptions along the way. Basically, they trusted me and I trusted them. My scope of practice is certainly not as broad as the DPC or concierge practices that are also being presented today. But I can see a healthy young person with strep throat who might see a doctor once a year, and the total cost of their visit, the strep test, and the antibiotic is $64. That person did not need a membership for me to do that, and no other clinic anywhere other than the free charity clinics can do that for less. That might be all that person would spend on medical care for a full year if it wasn't for the Obamacare tax they have to pay for not having health insurance, courtesy of John Roberts. A few years ago, thank you. A few years ago, Dr. Tim Ryan of the Physicians Practice in Cartersville, Georgia, wrote about his practice in the Journal of American Physicians and Surgeons, and I think that my practice is a lot like his, although not as comprehensive. He also likes practicing in a fee-for-service model rather than a concierge or DPC model, and he explains why in his blog. In the journal article, he said that his practice was a lot of fun, that it was good for his patients and good for him, and I feel the same way about my practice. Some might find ethical issues with my practice, including my lack of hospital privileges, but with the proliferation of hospitalists taking over inpatient care, very few family physicians see their patients when they're hospitalized these days, and my policy statement informs patients that I cannot admit them to a hospital or follow them when they are hospitalized, so they know that up front. I actually discourage patients from seeing me who are likely to need frequent hospitalizations for severe medical problems. Again, many of those patients have Medicare or Medicaid anyway, so they are much less likely to see me as their primary care physician. This may not be politically correct, but I sometimes bluntly tell patients that I have escaped from the government plantation and I'm not going back. Thank you. The Simply and Simply Family Medicine obviously has multiple connotations. It is just me and the patient. There's no team involved. There's nothing wrong with teamwork, but I'm really sick of that overused term. I generally take care of simpler medical issues, which might be unappealing to some, but I promise you that doesn't keep severe problems from walking through my door. I don't really have any time to tell stories about those, but every doctor who has practiced in a clinic setting for more than a few years has had patients show up with severe emergent issues. And almost every day there are interesting cases to keep me challenged and motivated. But it's my billing system that really makes it simple. At the end of each visit, the patient either hands me cash or their credit card. Billing typically takes 15 seconds per patient, and the only cost that isn't paid immediately is my monthly merchant fees for credit cards. There's no bad debt. I had a few hot checks early on, so I quit accepting checks. One thing you will need to decide before starting a cash-based primary care practice is how you plan to handle controlled drug issues, because those patients will find you. There's an endless supply, and they like paying cash. If word gets out that you will prescribe pain medications, before long they will be lined up outside your door. I do treat some chronic pain patients, but I've limited that significantly in my practice, taking at most a few new pain patients in the past 4 or 5 years. Obviously, there's significant risk involved in treating chronic pain patients, and there are always issues with their medications. I do believe that it can be done safely for many patients, and I particularly like treating those working class men and women who are out there trying to do manual labor jobs, who just need something to help them keep going to work every day so they can support themselves and their families. These folks are often self-employed, small businessmen or women, or independent contractors, and they often don't have health insurance. But what's really cool, it's also kind of neat that patients have to talk to me on the phone to schedule an appointment because I can screen them. It is rare for me to ever schedule a patient who calls stating, "I'm looking for a PCP." That is basically code for, "I'm looking for drugs." Every time. I use a simple, low-cost electronic medical record shared wirelessly on my 2 computers, but I only use it for my purposes. My notes are concise. I only document what I need in order to take care of that particular patient for that particular visit. Sometimes my notes are just a few sentences, although occasionally it might be a 3-page note for a 1-hour visit. Again, it just depends on the patient sitting in front of me. I read about all the problems doctors are having with electronic medical records, but I don't really understand it fully. And while there are apparently significant problems with EMR systems, these systems are not going to go away. I wish someone would bring an EMR to market, and maybe there are some I heard about earlier, that is just for third-party free practices. It would obviously be very different from the ones that are out there now. The fee for the great majority of visits to my clinic is $50 to $70, with some patients with multiple problems paying $80 to $120. Basically, I bill based on the amount of work I have to do, and I am the one who determines that with each and every visit. I only do 3 simple lab tests in my clinic: rapid strep tests, simple urine tests for UTI, and capillary blood glucoses. For other labs, I give patients lab orders to take to LabCorp or another lab of their choice, but LabCorp has lower fees for patients with no health insurance that they pay at the time of service. Plus, LabCorp typically faxes me the results the next day. I add a small fee to the visit fee when I order labs for the work that I have to do when the results come back. I also add a small fee to the visit fee when I order major studies or do referrals, again to cover the work involved. I consider this a common sense, fair system. Basically, I want to get paid for the amount and complexity of the work I do, and patients with multiple complex problems requiring labs or other studies or referrals to specialists should pay me more than patients with a single simple problem that is easily treated. I think that advertising is mostly a waste of money, but if I could find a low-cost way to effectively market my practice to patients with high deductibles and health savings accounts, I would do that. They seem to appreciate what I do as much as patients with no health insurance. When I swipe their HSA card, I don't take much off of it. My best referral source is happy patients. They go tell family members, friends, and coworkers about my practice. Opting out of Medicare and using absolutely no codes in my practice has caused some issues that I have not found a way around. I haven't talked to anybody here about this very much. After LabCorp sent me threatening letters when I did not include codes in the labs for Medicare patients, I stopped ordering labs and other studies for Medicare patients. And in Arkansas, just recently, Medicaid will no longer pay for prescriptions written by me. It is unknown to me why this has just changed recently. I've been doing the same thing for over 6 years. Arkansas is a poor state, and about 50% of children either have Medicaid or they are in a program called Our Kids, which is basically also Medicaid, thanks to Governor Huckabee years ago. Most of the other children are covered by their parents' private insurance, so I don't get to see a lot of children, which I don't mind too much. I still enjoy seeing children, but I would not have survived as a pediatrician. So greater than 80% of my patient population is 18 to 64 years of age. A very important issue for third-party free practices is keeping the overhead low. Other than paying myself, the rent is my largest overhead item. In 2014, after 5 years in my original location in a strip mall on the main thoroughfare in Fayetteville, I moved my practice to a smaller clinic in a smaller strip mall, still in a great location, and I was able to cut my rent in half. My 78-year-old father-in-law did thousands of dollars worth of free labor to fix up this 1,000 square foot clinic space, including building the window and desk from my picture earlier. And in my clinic, if it's going to get done, including cleaning the toilet, it gets done by me. I'm a loner. In closing, I am 59 years old, and I plan to continue practicing well into my 70s, God willing, and my health holds out. But if I cannot continue my current practice, if the government somehow makes what I do illegal, or says that I have to be tested for competence once I reach 65 years of age, I will find something else to do. I wear blue jeans to work every day. And while many doctors would say that I'm dressing unprofessionally, a lot of my patients get it, and they like it. My clinic is a Christian clinic, and patients know that when they walk in the door. Thank you. I consider my clinic to be my mission field. I treat everyone the same, the way I think Jesus would want me to treat them. Thank you for your attention.